Hello everyone, welcome back to today's session. We have successfully navigated the entire acute inflammatory response. We have had the vascular changes, the leakiness and hyperemia, and the cellular events, the magnificent yet destructive phagocytosis by the neutrophils. The battle has been fought, now the final crucial step. What happens next? Acute inflammation is not a terminus, it is a crossroads. The outcome dictates whether the host returns to normal function or is left with a permanent pathology. So, our session today examines the three possible fates of any acute inflammatory episode. This slide summarizes the three primary outcomes: resolution, which is the ideal outcome, healing by fibrosis, which is the necessary structural compromise, and finally, progression to chronic inflammation, which represents the fundamental failure of acute response. The path taken is determined by severity of damage and regenerative potential of the injured tissue. So, today we will decode resolution, healing, and progression to chronic inflammation, as in the ideal outcomes, scar formation, and persistent battle step by step. Resolution. Resolution is the textbook perfect outcome, the complete restoration of the site of injury to its normal histological and functional state. Think of this as the perfect cleanup. The damage was localized and the cleanup crew, that's macrophage, did their job and the original architectural blueprints were never compromised. The house looks brand new. So the prerequisites for resolution. For resolution to occur, several conditions must be met. The injury must have been mild or short-lived, such as superficial scratch or an uncomplicated low-burden pneumonia. Crucially, the basement membrane, which serves as a structural scaffolding for parenchymal cell growth, must be intact. If the scaffold is destroyed, organized regeneration is impossible. The damaged cells must be capable of effective proliferation. This applies to labile cells as in epithelial and hematopoietic, and stable cells as in liver and kidney tubules, permanent cells as in cardiomyocytes and neurons. So they cannot resolve this way. The transition is highly active and coordinated. So, mediator switch. The original pro-inflammatory mediators like histamine, prostaglandins are rapidly catabolized. New pro-resolving mediators such as lipoxins and resolvins are actively regenerated to terminate the neutrophil influx. This is the pivotal event, the macrophage phenotypic switch. The pro-inflammatory, highly phagocytic M1 macrophages switch to the anti-inflammatory, repair-promoting M2 phenotype. Inferophagocytosis. The M2 macrophages phagocytose the apoptic neutrophils and cellular debris. They then release anti-inflammatory cytokines, IL-10 and TGF-beta, which has dual roles but here primarily dampens the inflammation. Lymphatic drainage. The protein-rich edema fluid, the exudate, and cellular components are cleared effectively via the lymphatic system. The tissue can then fully regenerate. Outcome 2. Scar formation or healing by fibrosis. So, fibrosis occurs when complete resolution is biologically impossible. It's the replacement of lost tissue with non-functional dense connective tissue patch known as scar. This is the patch job. The original blueprint, that's our basement membrane, was burnt and you lost a functional section of the house. You must fill the gap with the strongest material available, a concrete wall, collagen, to maintain structural integrity. But that area can no longer perform its original function like pumping blood or transmitting a nerve impulse. So the prerequisites are substantial necrosis. There is a massive tissue loss, such as a large ulcer or deep abscess. Loss of stromal scaffold. The basement membrane is destroyed. Without scaffold, regeneration becomes disorganized and insufficient. Permanent tissue damage. The injury involves tissues composed of permanent cells. Myocardial infarction is a classical example, leading to cardiac scar. Exudate organization. Large fibrin-rich exudates are not cleared are invaded by fibroblasts and capillaries, a process called as organization. So, this process is especially a wound healing cascade dominated by connective tissue deposition, granulation, tissue formation. The site is rapidly invaded by new leaky capillaries, angiogenesis driven by VEGF, and proliferating fibroblast. This mix forms immature granulation tissue. Fibrogenesis, the M2 macrophages, now in their pro-repair role, become the primary stimulus. They release abundant TGF beta, which is the most potent pro-fibrocytokine. Collagen deposition. TGF beta stimulates fibroblasts to proliferate and synthesize excessive extracellular matrix, initially composed of delicate type 3 collagen, which is later remodeled to strong type 1 collagen for tensile strength. Outcome 3. Progression to chronic inflammation. Progression to chronic inflammation is the failure of acute response to eliminate the injurious agent. This leads to prolonged state lasting weeks, months, or years, characterized by a fundamental shift in cellular and molecular players. So this is the unending stage. The emergency response team, neutrophils, fail to dislodge the enemy stimulus. So the command calls in the long-term occupation force, macrophages and lymphocytes for a prolonged, low-grade and often destructive conflict. Prerequisites. The acute response is hijacked primarily by the persistence of stimuli. Resistant microbes, organisms like Mycobacterium tuberculosis or certain fungi that resist phagocytosis and survive intercellularly within macrophages. Foreign bodies, as in non-digestible materials like silica or talc. Autoimmunity. The inflammatory trigger is a self-antigen, lupus or rheumatoid arthritis, meaning the stimulus can never be eliminated. So it's crucial to differentiate the two processes. Onset is rapid. So here, however, in chronic, it's delayed. Dominant cell in acute is neutrophil, and in chronic, it's macrophage and lymphocyte. Primary process is exudation in acute and proliferation in chronic. Tissue injury is often mild and reversible in acute, severe, progressive, and fibrotic in chronic. Systemic signs are prominent as in fever and leukocytosis in acute, often subtle and low grade in chronic. And the cellular infiltrate changes from being predominantly PMNs to a mononuclear filtrate, that is macrophages, lymphocytes, and plasma cells, which sustains both tissue destruction and simultaneous repair efforts, leading to persistent pathological fibrosis. So, this flowchart summarizes the three critical paths an acute inflammatory event can take. This decision point is a vital concept in this pathology. Resolution, it's the ideal outcome. It requires the stimulus to be removed and the stromal scaffold to be intact. Result, complete structural and functional return. Fibrosis, the structural compromise is seen. It occurs when there is a massive damage or the tissue is composed of permanent cells. Result, a collagen scar, structural integrity restored, but functional capacity is lost. Chronic inflammation is the persistent battle. It's driven by the persistence of injurious agent and results in long-term mononuclear cellular infiltrate that drives ongoing tissue injury and pathological fibrosis. Understanding these three outcomes allows us to predict the functional consequence of a disease from a fully healed surgical incision to a crippling autoimmune disorder.